అవును సార్. యా చేస్తున్నాను సార్.
ల్యాప్టాప్ కదా నేను ఓపెన్ చేసి పెట్టు.
ఓకే సార్.
ఓపెన్ చేసి పెట్టి అప్పుడు ఏది కొడితే అప్పుడు మీకు అది దాన్ని ఓపెన్
వస్తున్నా సార్. ఇప్పుడు బాగాలేదు, ఇప్పుడు బాగానే ఉందా? హలో,
బాగానే ఉంది దినేష్
సార్. గుడ్ మార్నింగ్.
Yeah, good morning, sir.
సార్.
Dinesh, are you ready?
ఎస్ సార్.
Yeah, good morning, all. Now we are going to start venous access ultrasound in ICU, presented by Dr. Dinesh P. He is a consultant in Department of Anesthesia and Critical Care, Pinnacle Hospital, Visakhapatnam. Recently, he presented a paper along with Dr. Akshit in the Eurasia conference in Delhi. Now I request Dr. Dinesh to start the presentation.
Good morning, everybody. Today's topic is how to access, and I thank Dr. David sir for chairing this session. So before I begin, as a disclaimer, I would like to inform you all that this is a nascent topic, quite new for me, and the knowledge gaps can be expected in this topic, and any suggestions or inputs are appreciated from the audience. To begin with,
Dinesh?
sir. 1 minute.
ఏమైంది సార్?
ఏం తెలియదు, చూడాలి.
1 minute.
ఓకే. వాటర్ తాగుతున్నాడు.
ఆ స్క్రీన్ మీద ఈ డిస్ప్లే వస్తుంది సార్, ఈ స్పీకర్స్ ది డిస్ప్లే వస్తుంది, దాన్ని మినిమైజ్ చేయడం చూస్తున్నాం. దట్ ఈస్ అఫెక్టింగ్ మై వ్యూ ఆఫ్ ద పీపీటీ. యాక్చువల్గా నా స్క్రీన్ మీద వస్తుంది అలా.
But we are not getting anything. Okay.
నాకు వస్తుంది. Okay.
Yeah.
So to begin with, the venous side of the circulation has long played a second fiddle to the arterial side, which enjoyed much of the medical fanfare both in acute and chronic diseases. The arterial blood pressure is racing in its variations are more important to us, and we keep measuring it day to day and even minute to minute because we feel that arterial circulation is very important in terms of maintaining perfusion to the end organ. The venous side may be as important as the arterial side, and its physiological impacts on organ function is vastly more important than commonly thought. So even now, the Western countries are trying to concentrate more on the venous side of the circulation, and even microcirculation is gaining importance in terms of research when it comes to assessing perfusions in critically ill patients. So the true perfusion pressures of an organ is in fact not mean arterial pressures minus CVP, but rather the precapillary and the postcapillary venular pressures. So as a common notion, what we take is mean arterial pressure minus CVP will give us the end organ perfusion pressures, but that is not true, as you can see in this picture here, because at the level of arterioles and the veins, the pressure difference is much minimal. So if there is any increase in pressure on the venous side, a slight increase can lead to drastic change in the amount of perfusion the end organ receives. So the pressure gradient is much narrower, and the impact of raising venous pressures is much greater than it is commonly thought. So coming into the details of ultrasound and how does it work, ultrasound is a common imaging modality that allows visualization in real time. High frequency sound waves are transmitted from the transducer, and these sound waves are absorbed by the tissues, and they come back to the transducer, and there is something called piezoelectric materials which lead to transformation of one form of energy to other form of energy. That is already known by most of us, and these reflected sounds are then picked up by the ultrasound transducer, and then the sound waves are transformed into an image by the processor which is available in the ultrasound machine. So how do different types of tissues differ under ultrasound? So we should keep in mind that the different tissues will give different echo textures under the ultrasound, and we should be able to know what is what. So bones, fat, and stones produce a hyperechoic signal. Means the intensity of the signals which we receive back is normal is very high because they totally reflect. So a hyperechoic signal is bright, and most of the ultrasound waves are reflected. Cartilage muscle produces a hypoechoic signal. A hypoechoic signal appears dark as most of the waves pass through the tissue, and fluid-filled cavities produce an anechoic signal. Anechoic signal appears black as there is no reflection of ultrasound waves. Sometimes you may see a shadow can be noted on the ultrasound where there is hypoechoic area is located behind an hyperechoic area. This can be because of stones as we see in renal calculi, etc. So this is a typical USD picture which we can see here, where we can see all the common types of echogenicities which we regularly see while we do perform an ultrasound. On the top, we can see the hypoechoic areas, and then the anechoic and the hyperechoic. So this picture will give you a.
Dinesh, there is a break in your voice. I'm like crackling. Not continuous.
ఇప్పుడు ఓకేనా?
ఇప్పుడు ఓకే. ఏదన్నా ఉంటే చూడు డిస్టర్బెన్స్ ఏదన్నా దగ్గర పెట్టుకొని ఇయర్ ఫోన్స్. Yeah, now it's okay.
Yes. So these are the three types of echogenicities which we usually see in our day-to-day ultrasonographies. Coming to the type of probes, what type of probe we should use where? This is very important because this will affect the confidence of the intensivist or the anesthesiologist, a new intensivist or an anesthesiologist, because he may not be able to visualize what he wants to see, and this can differ the clinician from performing also in the initial phase because he is not able to visualize that. So selecting the right probe and using the right set of buttons to visualize what you want is very important, and we should keep an idea of what probes to use at what point. There are usually three types of probes available with us in most of the critical care settings. One is the linear probe. This has a very high frequency of around 7 to 15 megahertz. So this gives a very high resolution image, but the depth is somewhat on the lower side. So this is usually used by anesthetist in even intensivist in ICU setup to get vascular access or nerve blocks or assessment of lung tissues, superficial lung tissues mainly. We can assess pleural sliding with this. And then the other probe is the curvilinear probe. This is having comparatively lower frequency when compared to linear probes of around 2 to 5 megahertz. It has low resolution but has greater depth. So this is useful for assessing abdominal, pelvic, and deep lung tissues. And the third is the phased array probe. This is the lowest of all, 1 to 3 megahertz, and this we use regularly for the purpose of echocardiography. So these are the types of probes. Just to visually appreciate them, towards the left is the linear, and the center is the curvilinear probe, and the other one is the phased array probe, which is the cardiac probe. So what are the various modes of ultrasonography? There are three types of ultrasonography modes which we should be aware of. The first is the A mode. A mode is the simplest type of ultrasound. So a single transducer scans a line through the body with the echoes plotted on the screen as a function of depth. And the therapeutic ultrasound aimed at a specific tumor or calculus is also in A mode to allow for point accurate focus on the destructive wave energy. So this is mostly used for targeting tumors or calculi. This is not used by us usually in our clinical setups. Then comes the B mode or the brightness mode. Here, a linear array of transducers simultaneously scan a plane through the body that can be viewed as a two-dimensional image on the screen. So whenever we switch on the echo machine and we see the image, that is usually the B mode. It is a two-dimensional image. That is usually the B mode which we see. And then comes the M mode. M mode stands for motion. In M mode, a rapid sequence of B mode scans are continuously given, followed in a sequence on the screen, enables the doctors to see and measure a range of motion as the organ boundaries that produce reflections move relative to the probe. So M mode is usually stands for motion mode, where we can appreciate the boundaries of various organs moving. This we regularly use in lung ultrasound and in quantifying mitral valves, etc. Mitral valve functions mainly. There is another mode which we should be aware of, that is the Doppler mode or a Doppler ultrasound. In Doppler ultrasound is a non-invasive test that can be used to estimate the blood flow through your blood vessels by bouncing high-frequency sound waves of the circulating red blood cells. A regular ultrasound uses sound waves to produce images, but it cannot show flows. So if you want to know the flows, there is a different principle embedded into our ultrasonography machines, so known as a Doppler ultrasound. This gives you the information with regard to flows of the blood. So again, in Doppler, we have two types of Doppler. One is the continuous wave Doppler that transmits ultrasound continuously, and other one is pulse wave Doppler that transmits ultrasounds in short pulses. So what is the advantage and disadvantage of both this is, in continuous wave Doppler, this helps in measuring high velocity flows, but the range resolution is very poor in them. So in pulse wave Doppler, the advantage is they have good range resolution, but the velocity, they are able to detect low velocities. So that is the main difference, and we should try to understand this because this will help us in quantifying the results whenever required. So coming to the next topic, point of care ultrasound, and this is a new development in critical care where bedside ultrasound has shifted towards point of care ultrasound. So the development of point of care ultrasound has given acute care clinicians with a powerful tool to assess patients bedside. So this point of care ultrasound helps us in determining the diagnosis and providing interventions at the same time and correcting our therapeutic goals in real time instead of waiting. And point of care ultrasound has infiltrated into almost all specialties of medicine and patient care. Coming to anesthesia part here in this, you can see point of care ultrasound is involved in guidance for vascular accesses, regional anesthesia, intraoperative monitoring of fluid status and cardiac functions. And at the same time, if you go for critical care medicine, it is used for procedural guidance, pulmonary assessment, and focused echocardiography. So venous access ultrasound, by the short word of venous access, VEXUS score. This is part of the focus. It is a quantification tool to know if there is any organ congestion happening in the patient. It is a fast and valuable tool to evaluate venous congestion at the bedside and identify hypervolemia in patients, helping the physicians in therapeutic decision making. So the clinical application and research of this VEXUS ultrasound is mostly involved in post-op cardio patients to prevent cardiorenal syndrome and hypervolemic hyponatremia. I mean to say that most of the studies done on this topic, or which introduced this topic, they were done on these set of patients. There are very limited resources or very limited number of papers which discuss about vexus, but its importance is increasing in clinical practice in Western countries. So how to perform a vexus ultrasound and where we have to look? So there are 4 points which we should keep in mind. It can be done by 4 steps. The first is you look for the IVC, and then you see for the hepatic, portal, and renal veins. Here in this picture, you can see the sequence which we have to follow before we start doing vexus ultrasound. So how to perform vexus ultrasound? There are 4 steps in performing vexus ultrasound. So to begin with, step 1 in this, we need to see whether the IVC is really distended or not. Because if the IVC is not really distended, it brings the patient into a category of not having any congestion. The patient may still have congestion. We will talk about the sensitivity and the specificity of this test in the later stages of discussion. But to begin or to learn how to perform vexus, we'll keep it simple. So step 1, in step 1, you should use a curvilinear probe, or if people who are comfortable using phased array probe, they can screen for the inferior vena cava and look for venous congestion. So how will you say that there is venous congestion according to vexus? So we should determine the size of the inferior vena cava in M mod if possible. And if this is less than 2 centimeters, proceed to no congestion, no further assessment. If it is greater than 2 centimeters, you have to proceed to step 2. Now, how will you perform ultrasound to know the size of the IVC? So in a subxiphoid cardiac view, at the level of epigastrium, place your point, keeping the pointer towards the sternum, and you slowly fan the probe laterally to view the IVC draining into the right atrium using M mode in a sagittal plane. So here you can see a graphical description of what we'll end up seeing under the ultrasound towards the right side. There you can see the IVC opening into the right atrium and the liver. This is the usual picture which you see while you scan for the IVC. So in the center, we can see 2 cylinders with different lines being drawn through them. So this is something called cylinder effect. For the beginners who are trying to do and look for the IVC, we may fall prey of the cylinder effect, where you may not be visualizing the entire IVC because you are towards one margin and you feel that the IVC is of lower size comparatively. But the reality is that if you go to the center of the IVC, the size may be much bigger. So one of the pitfalls of this view is that any view, when it comes to 2-dimensional view of a cylindrical structure, is this cylinder effect. So how would you differentiate IVC from aorta? So the visual, the pulsatility can be seen, and color doppler can be used. That will give you IVC can be differentiated from aorta based on visual appreciation of pulsatility, and perform an M mode on the IVC to determine its size. So I'll just slide back and try to show you the buttons on our echo machine or ultrasonography machine. Here you can see the M mode. So once you see the IVC, click on this M mode and try to trace for this, try to find a trace similar to this, and you can use the caliper and you can measure the size of the IVC. If this is more than 2 centimeters, there is a possibility that you can quantify vexus in this patient, and you can go for step 2. So what do we do in step 2? In step 2, we assess the size of the hepatic vein, as we spoke earlier. To assess the hepatic vein with the probe in B mode, start in the right upper quadrant in the transverse plane, fanning the probe anteriorly and posteriorly, and pulse wave of the of the vein can be obtained. So here on the left side, you can see the IVC and hepatic veins entering into the draining into the IVC. So this is called a bunny sign. You can see it. It looks like a rabbit. So it is called the bunny sign, where the IVC is well distended and the hepatic veins are draining into this. So you can obtain a pulse wave Doppler of the hepatic vein in this position or in this view. There is also another option where you can visualize the hepatic and portal veins together in the mid-axillary line in the coronal plane, with the pointer pointing towards the sternal notch. Blood usually flows away from the heart, so it can be appreciated in blue color. Sometimes, as said, you can appreciate even the portal vein in the same window, which will reduce your time to look for the portal vein. So coming to the normal hepatic vein Doppler waveform, these waveforms uh, in this vexus we have an advantage because we need not interpret the waveforms or their calipers or anything. It is a pictorial description. So you see what you see, and you have a chart with you or in your mobile. You can see, and you can compare it with what you are seeing, and you can quantify it. So there is no requirement of understanding all the dynamics of ultrasonography and all the waveforms. All this is not required. The only advantage of access is that it is a pictorial description where you can see and immediately understand what is happening to the patient. That is one advantage we have with access. But still, for discussion purpose, now how to assess this hepatic vein Doppler waveform, normal Doppler waveform of an hepatic vein. So here we can appreciate three waves mainly: A wave, S wave, and D wave. So what is happening above the line and below the line? So above the line, the blood flow is towards the organ, and below the line, the blood flow is towards the heart. So what does A wave imply? A wave implies atrial contraction. So whenever there is atrial contraction, there is some backflow happening towards the liver, and this you can see as A wave in this waveform. So S and D shows the systolic and diastolic waveforms where there is forward flow, and as I've already said, the thumb rule is whatever you see above the baseline is flow towards the end organ. Okay, whatever you see below is flow towards the heart. So there are predominantly three waves we have to remember in hepatic vein. One is hepatic vein Doppler. They are A wave, A, S, and D waves. So A is because of the atrial contraction. S and D are because of the forward flows happening from the left ventricle, which are emptying the blood flow. So how would you quantify congestion using the hepatic vein Doppler? Hepatic vein Doppler. So normally the S wave is always greater than the D wave. The systolic wave is always greater than the D wave. So as congestion increases, the diastolic wave increases in size, and the S wave reduces in size. And at one point, at grade 3, where you can see here, there is severe abnormality, there will be reversal. So S wave almost goes to the other end of the baseline, and you see this biphasic pattern happening in the patient. And step 3, how would you assess the portal vein? So once you are done with hepatic vein, you go for the portal vein. So how would you assess the portal vein? This is the easiest vein to obtain waveforms, and it is most quantitative. You can use the curvilinear probe as discussed earlier, or even the phase area probe we have tried using. I am able to get the waveforms in patients. The curvilinear probe can be used with abdominal presets is preferred. Position the patient in coronal plane. Position the probe in the coronal plane of the patient in the right upper quadrant, mid to post axillary line, and fan the probe anteriorly and posteriorly. Portal veins are easily identified by their thick and bright hyperechoic walls. Continuous wave Doppler of the portal vein should give you light up with red to confirm it is portal vein. Here, the main another way to differentiate between hepatic and portal veins in one window when you see them is in portal vein the blood flow is towards the organ, so you should be able to see it in red color because it is the blood flow is towards the probe. And when it comes to hepatic vein, the blood flow is towards the heart, so it is moving away from the probe, and you should be able to appreciate it in blue. However, sometimes you'll be able to see a police siren sign. So this police siren sign is something where there is constant alteration in the color of the portal vein flow. There is a red and blue, red and blue, red and blue coming and going. This suggests that there is flow reversal and severe congestion in patient. So this is the angle where how this picture shows how to position the probe in the patient, and this is a pictorial image of the portal vein. So how to identify portal vein and how to differentiate it from hepatic vein? So it is very easy because as we spoke earlier, the bunny sign or the rabbit sign, here you can see a deer. The portal vein looks similar to a deer, and the portal vein walls are quite thick. So you can easily appreciate this in any patient, and because of the thick vessel walls. So this helps you to differentiate between a portal vein and hepatic vein. So in portal vein, as you can see the waveform here, as I've already said, all the flows above the baseline are towards the organ, and below the baseline are away from the organ. So here you can see, since the blood is coming towards the liver and towards the probe, so you can see flow above the baseline. So the normal portal vein flows are usually flat because exact venous pressures are masked because of the hepatic sinusoid. So it is usually flat with variations produced in the pulsatility because of respiration. So here we can see three types of waveforms based on the flows we have and pulsatility. We have to decide what type of congestion we are expecting in the patient. So when it comes to portal vein, so you can see the pulsatility is less than 30%. That says that there is mild abnormal, that the flow is normal. Mild abnormality is pulsatility between 30 to 50%, and the severe abnormality is when pulsatility is greater than 50%. So step 4 is how you assess the intrarenal vein. Similarly, you can use a curvilinear probe in this case. The final abdominal vessels we scan are the intrarenal veins, and this is the toughest part to assess because the patient can be breathing and the patient may not cooperate, and most of the time is breathing with high respiratory rates or any condition where the patient is uncomfortable. You may lose the visibility, or since the window keeps on moving, and you may not be able to appreciate intrarenal veins. But many experts who are doing access say that the appreciation of intrarenal veins is quite subjective, and they're even trying to look whether they can replace the renal vein with splenic vein so that they can quantify organ congestion in a better way. So these are the final abdominal vessels to scan, and small veins and arteries of the kidney. These vessels are the most challenging to identify because of their size, particularly with habitus of obese patients. This is further confounded by patients in respiratory distress that are tachypneic, making the windows quite challenging. So how do you see these intrarenal veins? Starting in the posterior axillary vein, identify the renal cortex and the interlobar or arcuate renal veins within. This is very difficult to do, and you may not be able to appreciate most of the times. You were able to appreciate only 50% of the cases which we regularly assess in our setup. Maybe sometimes even less, maybe 50%. Yes. The arteries and the veins run anti-parallel to each other, facilitating simultaneous acquisition of both the artery and the vein within the single pulse Doppler window. The artery will produce a waveform above the baseline, whereas the vein will produce a waveform below the baseline. Uncongested renal veins have a continuous monophasic flow. With increasing venous congestion, there is a decrease in the systolic flow in a progressive fashion until the waveform becomes pulsatile and then biphasic with discrete diastolic and systolic waves. So this is the propositioning with the pointer facing towards the shoulder, and on the right top you can see a normal looking kidney in D mode. So once you put the color mode, you should be able to appreciate something similar to this, where there is haywire appearance of all blue, green, or blue and orange happening and red happening in the patient. So once you put the pulse wave Doppler in these patients, you should be able to see a similar waveform which you can see on the right side. So as spoken earlier, whatever is flowing above the baseline is towards the organ. So that what we are seeing on the top is the arterial trace or arterial waveform, and the one below, which is quite flat, is the venous waveform. So what happens with as the congestion increases is you will be able to appreciate a systolic wave and a diastolic wave, and as the congestion further increases, you will be able to see only a diastolic wave. So based on this, we can quantify the patient into normal, mildly abnormal, and severely abnormal. So this is the final picture or go-to picture which we should keep in our phone or wherever it is accessible. Take a printout or keep it. If you're really interested in doing this in patients, really pick up a habit of assessing the waveforms. So there are 4 locations which we have to see. One is the IVC, followed by hepatic vein, portal vein, and renal veins. So in step 1, you see if the IVC diameter is greater than 2 centimeters, then you go to step 2, where you assess the hepatic vein Doppler, and you see whether it is normal, mildly abnormal, or severely abnormal. In the similar fashion, you do it for the portal and renal veins. In the portal vein, you see for the pulsatility index whether it is moving whether the pulsatility is less than 30%, 30 to 50, or greater than 50%. So this is purely a visual appreciation. You don't require any kind of calipers to be used. But that gives an advantage of using vexes because ultrasonography and is a quite vast subject, and many of us may not be comfortable or find it difficult to understand on how to perform those modalities which require calipers. And then you have step 4, where you can see the renal vein Doppler. And again, you will differentiate into normal, mildly abnormal, and severely abnormal. As you can see, there is a continuous monophasic flow. And in mildly abnormal, it becomes, it gives a systolic and diastolic flows. And then you have discontinuous monophasic flow, where you see only the diastolic. So there are 3 grades. Grade 0 is where the IVC is less than 2 centimeters and there is no congestion. And you have grade 1, 2, 3. It is mild congestion, moderate congestion, and severe congestion. So you see the IVC, see what is happening in hepatic vein, portal vein, and renal vein, and just look at the waveform and put the patient in the particular criteria. And this may help you in regulating the amount of volume you give to the patient, or you can experiment in your own setup, and you can decide for yourself whether it is really working in the patients or not. And the advantage which we get by doing this is we'll be able to appreciate more of abdominal anatomy, and we'll be getting more familiar with EFAST and other procedures, because we keep seeing this anatomy and we keep appreciating the flow. So the one of the there are different types of pictorial descriptions available. If you're okay with these drawings, you can go ahead with the drawings, or there are real-time images which will put the patient in the required grade you want. So there are different types of vexes which were developed for research purposes, and currently we are using vexes 5C. So the question arises why we are using Vexus type C and not other types, because many research and meta-analysis say that IVC going deciding fluid management based on IVC has only has sensitivity of around 41%. But when it comes to other components of Vexus C which are used in this, like the portal vein, hepatic vein, and renal vein, they have high specificity of around 75%. So they've added IVC into Vexus type C, and the Vexus type C is commonly being put into practice in almost all research and clinical purposes. So that is the reason why Vexus C is used, because there is increased sensitivity and specificity to this. So this is another pictorial image, go-to image, using which you can decide whether the patient is congested or not, and whether we should bring down the fluids in these patients or whether we should give them more fluids. But this usually tells when to stop and how to stop. We don't know how further research will guide us, but they are trying to add the splenic vein also into this, and reduce the dependence on intrarenal veins, because they're difficult to visualize. So there are some pitfalls and limitations for this. Like any test, confounders exist that can make Vexus findings ambiguous and hard to interpret, mainly in conditions where the native pressures, the end organs, like cirrhosis with fibrosis or renal diseases like stenosis and all, they can lead to natively high pressures, and in these patients, assessing Vexus may not be possible. And in constrictive pericarditis, pulmonary embolism, increased abdominal pressures, or if there is tricuspid regurgitation in all these patients and patients with positive pressure ventilation. In these cases, also sometimes you may not be able to, and even in atrial fibrillation, they can mask the A waves, and making the interpretation of Vexus unuseful and not worthy in these patients, because you'll not be able to know whether there is real organ condition or not. And practice and familiarity with this technique and what to expect can reduce these issues and help guide in taking better care of the patient. Thank you.
Thank you, Dinesh, for a nice presentation. Any questions from the audience? Hello?
Dinesh,
Yes,
nice presentation.
Thank you.
Suppose if you are unable to visualize the IVC, suppose in a post-operative case, post-operative upper abdominal surgeries, like post-operative any thoraco-abdominal surgeries, what is your approach?
Sir, most of the time we should be able to visualize IVC unless the incision is in the midline where you are not able to visualize the IVC. Maybe then in the coronal planes, we should be able to appreciate IVC, sir, because it is a cylindrical structure. If you are not able to see in the sagittal plane, we should be able to see in the coronal plane. Unless the patient is very bad and there is abdominal distension and there is severe sepsis, if you are not able to visualize, yes, that is one of the pitfalls. But usually, if you're not able to appreciate in the sagittal plane because of any incision,
is there any approach in that condition to can we visualize the IVC instead of
yes, sir. That's what.
Any other view? Any another view?
In coronal plane, yes, sir. In coronal plane, we can
coronal
appreciate.
plane also we have to keep the probe and it means subjectified position. So in these conditions,
if it is not possible in the subjectified position, then you go for the mid-axillary line. In mid-axillary line, you should be able to appreciate the
laterally mid-axillary line in right subhepatic area. We retrocardiac. We can able to.
We can appreciate.
In that area. That is the one.
Because sometimes when you are not able to, even I am not able to see sometimes IVC, in those cases I usually go for the mid-axillary line in the coronal plane and I go for the quantification of IVCs.
No, without seeing the IVC, can you If you are unable to
No,
see
sir.
IVC,
No, sir. No,
can
sir.
you go
IVC
directly to see the portal veins and the renal veins?
no, sir.
No.
Because if you fail step, that is what step 1 will decide whether the IVC is more than 2 or less
Without
than
step 1, can you go to step 2, 3, 4?
No, sir. Not possible.
Because you
The
are
main
unable
limit.
to see. If the
Yes, sir.
congestion is there in the organs,
Yes, sir.
the waves will be visualized, no? As you said, this grade 2, 3, like that.
That's what, sir. But I don't know. None of the literature available till date.
We will do that. We will
Yes,
create
sir.
the literature. See,
Because
without step 1, how to perform
that's why they're already trying to sideline a renal vein and add splenic vein into this. Because even when
Yes, sir.
Without step 1, step 2 going for jumping.
అంటే జంపింగ్ కాదు, అంటే దిస్ ఇస్ సబ్జెక్టివ్ ఆల్వేస్. అల్ట్రాసౌండ్ ఈజ్ ఏ సబ్జెక్టివ్ వేరియబిలిటీ. If you are unable to perform due to several reasons, that obesity or ascites, something else, or post-operative, can we go directly to step 2, step 3? Or
no,
step
sir.
4?
And the other advantage is here we are not measuring any caliper. It is only pictorial appreciation. So this inter-observer variability will come down if you have minimal capacity to obtain these waveforms and do the basic ultrasonography, obtain these waveforms. So we just have to get the waveforms and compare with the waveforms which they have. So since there is no calipers or any measurements involved in this, so that inter-observer variability is coming down a bit compared to other techniques. So that is one advantage we have in this VEXUS ultrasound.
Yeah.
Yes.
Another thing, if patient comes with hypotension, your IVC is more than 2 centimeters and non-collapsible, and there's no need of going to other steps. Okay, but patient is in hypotension. LV is empty. I mean, LV having a kissing sign and contracting vigorously. RV also is small size, but IVC is distended and non-collapsible, more than 2 centimeters.
In
Can
that
you go
case,
ahead and give fluid, madam? Hello?
See the confounding factors.
Yeah. So you have to
Patient in F.
manage this patient.
yes,
Fluid management.
yes, sir. There are many conditions where we will not be able to assess or help in. This is not the main aim of this is not to decide how much fluid we have to give, sir. This all the studies done till date are done in resuscitated patients or in patients who are already in established hypervolemia, in whom there is a chance of reducing the fluid administration. In
No,
those
Dr.
patients,
Dinesh,
yes.
what sir is asking is, see, already you don't know the patient has been resuscitated or not in the outside
Yes.
hospital. So
Yes.
the patient came to your hospital after 5 days of stay at the other hospital. So how will you decide the patient is resuscitated or not? That is sir's question.
No, sir, if the patient comes to me with good RV and LV function and distended IVC, I would look into different the entire topic of resuscitating or reviving the patient will shift. That is my management will not be decided based on VEXUS. That is. So that's what I mean to say, because why we are performing VEXUS is to see whether there is fluid overload or not. But sir is saying that RV and LV are already empty, and we have to look for other reasons of congestion, and I'll try to assess VEXUS in this patient also and see if there is really any organ congestion happening in this patient. But that is not going to change whether I give fluid in him or not, because RV and LV are empty in the first place, and there is good contractility of RV and LV. So we have to think of other things also before we taking up a decision in this patient. Maybe even if the IVC is 2 centimeters, then the patient may be in AKA or C in AKA and such cases. Yes, maybe even diuretic will help in this patient with a slight amount of fluid. So we can't definitely say that VEXUS should be done in this patient or it should not be done in this patient. This is just a modality which will help you to quantify in some cases, maybe. In some cases, yes, it is still in the gray zone. We don't know. and still they are trying to add more organs into assessing this. And because RV and LV functions are okay in this patient and they're empty, yes, maybe we have to think of other things also, and we have to look for the blood pressures and all, and then decide. This is not the sole diagnostic modality in any way.
Okay, Dinesh.
Yes, yes.
Any questions? You showed now what one probe, all-in-one probe.
Yes, sir.
Is it available?
I don't know, sir. Maybe
It is available with some new ultrasound machines, sir, but it is not very effective.
Okay.
And what the picture is showing out the butterfly one, it is very costly.
Which is the butterfly one?
I'll show one
Butterfly and company, sir.
ఆ పిక్చర్ ఉంది కదా సార్ పైన బ్లూ
Picture lo
కలర్
company blue color butterfly ఉంది కదా అది.
All in one. కాదు, యా అయిపోయిందా ఇది? మేం లేదు. Congratulations Dinesh for presenting in Eurasia and Delhi the same vexes nicely, and
Thank you,
your
sir.
team conducting this. First, second is Anuradha is in this one. Anuradha is in team or not there?
లేనట్టున్నారు సార్.
Okay, happy birthday to Anuradha. And we have a Dr. Chetan Govind Shirodkar from Apollo Secunderabad who joined the class. Is Chetan is available? Dr. Chetan?
Yeah, good morning, sir. This is Dr. Chetan.
Hello.
Yeah, good morning. Good morning, everybody.
Hello, Dr. Chetan.
Yeah, good morning, everybody.
Chetan is there.
Yeah, his voice we are not able to hear.
Can you hear me now, sir?
Yeah. Very, very low voice. Maybe it's okay. Anyway, welcome to the group. And thanks for the class joining. And definitely your contribution, your involvement will be very useful to you and to us. Thank you.
Yeah.
And regarding the vexes, I request Dinesh and the team, along with Akshit or whoever it is, to conduct one workshop for this, if it is useful for all of us.
Yes, sir.
Yes.
Sir, this is from my side, David sir. Thank you.
Okay, sir. Any questions from audience? Dinesh, can you?
David,
Yeah, sir.
can you arrange means direct patient to patient workshop like that within 1 week regarding on this venous axis?
Patient to patient.
And means bedside.
Bedside.
Ah.
Bedside. Yeah, we can do that. It's not
Because
issue.
just now he has enriched with this new venous axis ultrasound to all of us. No?
Fully enriched.
డేవిడ్ సార్ ఆ రోజు పేషెంట్ కు 5 లీటర్ల ఫ్లూయిడ్ ఇచ్చి వదిలేయండి, మేము వచ్చి చూసుకుంటాం.
5 లీటర్ల ఫ్లూయిడ్ ఇచ్చి వాడు డిస్నిక్ కావన్నప్పుడు ఫోన్ చేస్తాం అప్పుడు రండి.
ఎందుకు లేదు సార్, ఏమి వెరైటీ ఆఫ్ కేసెస్ యూ విల్ గెట్ నాక సార్ పినాకిల్.
Any intubated patient will be good, sir, to observe.
Dr. Dinesh, what is pulsatility fraction?
Pulsatility index, sir.
Pulsatility fraction or ratio.
Pulsatility ratio is the ratio of I think systolic minus diastolic divided by the systolic pressure. That we see in arterial flow cycle, pulsatility ratio. That will I think it should be kept by less than 0.8 to 0.7 is what I remember, sir.
Any similar terms, what you see for AK and all those things?
I remember it being used for our transplant patients, sir. Whenever there is some issues of graft rejection and so, we go for pulsatility index, sir. and see for that, and we try to target 0.8 to 0.7.
Have you heard anything about resistive index?
Yeah, resistive index. Yeah.
Anyway, we are almost doing regularly this VEXAS scan on bedside, particularly in patients who are cardiac patients and renal patients, having breathlessness, lung congestion of B rays are increased. At the same time,
సార్ అది ఇప్పుడు ఆల్రెడీ బీ లైన్స్ వచ్చేసిన తర్వాత మీరు వెక్సెస్ చేసి will you get any more information?
Definitely is adding point that already other organs also congested, that waves are all grading is increased. At the same time, B lines are
అంటే
there.
బై డిఫాల్ట్ లిటరేచర్ మనకి తెలిసిన లిటరేచర్ వరకు బీ లైన్స్ ఉండే ఐవిసి is full, will stop our registration and will start with
definitely
diuretics.
we will stop registration and previously we don't have the facility to do this VEXAS scan. Now after seeing the B lines, again we check the VEXAS scan and see all other organs also congested. Then we can start this diuretics. We have given diuretics to
No, what I wanted to say is rather than in a patient who is having a systemic illness, maybe an intra-abdominal pathology or a cardiorenal syndrome might be a good patient for this VEXAS criteria.
Yes, and the other thing is IVC,
because organ congestion అనేది మీకు ఈక్వల్ గా ప్రతి దగ్గర ఒకేలాగా స్టార్ట్ అవుద్ది. either it can be lung, either it can be liver, either it can be kidneys, or it can be spleen. But if it is a general thing, we won't be able to get like అంటే ఒక additional information ఉంటుంది, but may not be very much useful. But where there is a pathology where you see an only congestion in kidney and liver and not much in the lungs, in those conditions, in case of CLDs, so those patients, IVC, collapsibility or index, these things won't work in a very good way. So in those patients, we might
there are a lot of limitations.
IVC per se has sensitivity of only 41%. Sir. I don't know what is the sensitivity of lung showing B lines in the ultrasound. So when it comes to hepatic, portal and renal,
B lines have when there is B pattern, in the sense there is fine B lines, the sensitivity goes up to 80 to 85%. When there are coarse AB profile, then your sensitivity differs.
So this has sensitivity of around 70%. ఈ ఐవిసి కాకుండా మిగతా 3 తీసుకుంటే that is increasing both the sensitivity and specificity of the test. So that is the reason why they've added hepatic, portal and renal veins. Maybe yes, as you said, B lines also help. Yeah, maybe they are much better way to quantify organ congestion. And as you said, organ congestion develops in all organs simultaneously. But maybe this is a different modality where you can assess organ perfusion. That's it.
Dinesh, Akshit wants to ask one question. Akshit.
Okay.
Hello.
Akshit want to ask or Akshit want to answer?
He wants to answer. Yeah, whatever it is. Akshit. Hello. చేయి పెట్టాడు మరి చాలేనా చేతి అర్థం ఏంటి మీనింగ్ ఆఫ్ హ్యాండ్ ఇంక చాలు ఆపోయినా లేకపోతే వాంట్ టు ఆస్క్ క్వశ్చన్ అయినా
హ్యాండ్ అంటే సతీష్ సార్ అనుకుంటా
అక్షిత్ అని ఉంది అక్కడ హ్యాండ్ ఇచ్చాడా నీకు దినేష్
ఏమో సార్ తెలియదు
ఇద్దరు కలిసి ప్లాన్ చేశారు ఢిల్లీలో సో ఇట్స్ ఎ గుడ్ modality.
Okay, as Mohan Rao sir asked to arrange this bedside VEXAS scan within 1 week. అదే కదా
సార్ డేవిడ్ గారు
1 week లో పెడదామని అడుగుతున్నారు మీరు
అవును అంతే సార్
సరే సార్ పెడదాం ఎక్కడ
మన టీమ్ కి
మన టీమ్ కి
మీ దగ్గర డేవిడ్
లేకపోతే